Perfect. We are recording now, which means at the end of the session today, you will get a copy of the slides, you will get the recording, and this is good for CEUs as well, which you will get following today's session. If you've got questions, feel free to reach out in the chat. I will be monitoring at a couple of points today, but we will keep this moving pretty quickly too, just to make sure it's really valuable insight, intel. And if you do have questions, if we can't get to them in today's session, we will make sure that we do. With that, we will go ahead and get rolling. So provider trust, if you don't know who we are, a few of you guys are brand new. Who we are is we are a healthcare data company. We are based in Nashville, Tennessee, and we believe that a smarter healthcare makes a safer healthcare. What that means very tactically is what we do is we monitor healthcare populations to identify compliance and credential issues before they impact patients. So much of the content that we deliver for free, especially to folks on the phone, is based on how do we help make healthcare smarter. And every now and then we get to introduce new guests and new faces and new topics into our monthly education that focuses on, if we make it smarter, how do we make it safer? And with today's session, it is certainly connected to the safety piece of our brand statement and brand mission. For those that don't know, we are based in Nashville. We'll touch on this at the end, but we offer free content all the time. So if you guys are looking for CEUs or a way to learn or engage, feel free to browse our website, providertrust.com. There's plenty of content and resources there for sure as we go. And with that, we're going to talk about a topic that I'm thrilled we are talking about today. Racial inequities and minority representation in healthcare. Specifically, I'll get into the agenda in a second, but we're just so excited that we can introduce this topic and offer something to the conversation. And I'll explain specifically what that is. Today's presenters, certainly I'm one of them. My name's Dave. I lead our marketing at providertrust.com, which includes part of patient advocacy as part of our brand story and our message to the marketplace. And then I'm super excited to have as our guest today, Dorinda Walker. I'll let her introduce herself.
Hello, everyone. I hope you're having a great day. My name is Dorinda Walker, and I'm just here to help give you guys some insight as far as the patient perspective. I'm helping to lead the Health Push, which is an initiative that's started by Provider Trust, and we'll get into more info on that later. But super excited to be here with you guys today and hopefully provide some good info for you all.
Awesome. We are thrilled to have Dorinda. We often have industry thought partners join us that are compliance executives and HR executives from health systems, both from providers and from payers across the country. And we thought we'd do something a little different today and invite patient advocacy to be a contributing voice to some of our content, which we're excited to bring throughout today's presentation. With that, today's agenda, we're going to start with the safer healthcare for everyone. I'll explain that in a minute in terms of what that actually means, going through data on minority and racial representation in healthcare and hopefully walking away with some insights. COVID as a case study. We're not going to spend a lot of time on COVID, but it does have really good info if we look at exacerbated impacts and inequities for specific vulnerable populations. We are going to spend a lot of time on connecting racial inequity to healthcare, to patient safety. So much of what we do is partner with HR, compliance, and C-suite leadership across providers and payers in healthcare today. There is inherently a piece of this conversation that connects back to how to keep people safe, which is our brand promise and what we hope we can inspire in so many of the attendees today. And we will spend some going through the data that we've got to share is pretty impactful and directly ties to the work that so many of you do. And then certainly, as always, we will leave you with actionable next steps that you can take to advance your HR and compliance initiative, certainly in Q4, but as we go into 2021 as well. We'll leave you with a couple of resources too. I think for all of us, this is a conversation that we are hoping to listen and learn on an ongoing basis. Speaking to you as a white male executive in healthcare, there is so much that I continue to learn about this topic and how to make both our organization and healthcare as a whole better. And I'm so excited to at least point a few of our friends in the right direction around this. So, a safer healthcare for everyone. I want to start by saying a quick word from us. Provider Trust, this is a screenshot of our blog and a post that we made on June 4th of this year in support of Black Lives Matter and a commitment from provider trust to be better. And so many of the organizations that we know are on the phone made similar commitments and similar posts that I've followed around from a marketing perspective. And this is an invitation into our journey as provider trust continues to stumble bravely but passionately in increasing certainly equity in healthcare, but trying to create a safer healthcare for everyone, which from provider trust's perspective, our purpose as an organization is to create a safer healthcare for everyone. That's how we decide what content to publish out. It's how we decide what products to build. It's how we decide who to hire and who to promote at our organization. It's how we make decisions, and it's a foundation for our culture, which means it comes back to everything we do. And we're so excited to be able to contribute to that in a really meaningful way. Moving forward, representation matters. We wanted to start with a quote that was really impactful. There are so few ethnic and racial minorities around the table when they're making decisions on what type of healthcare services are we providing, who's providing those services, what will enhance and inhibit utilization, that the policies that often come from these decisions don't necessarily reflect the needs of the community, which is where we'll spend some time today, and specifically, how do we take insight to action to better represent the needs of the community in healthcare today. I wanted to include just a couple of snapshots of data from a macroeconomic perspective. What you're seeing is a recent survey in August of 2020, so this year, just a few months old, of a survey done by Modern Healthcare of minorities in senior management. And what Modern Healthcare was able to show is that often through this auditing process, organizations that do not have significant minority representation in senior leadership are less likely to make racial health inequities a priority. Only 31% of hospitals reported having a documented plan to increase the number of minority executives in senior leadership roles, according to the American Hospital Association's benchmark data. And a healthcare organization's success for improving diversity throughout its ranks comes down to a will to make meaningful change from top down. I wanted to stop here for a second and saying our objective today, we talk a lot about feelings at Provider Trust, and our objective today is certainly not shame, it's not guilt. We're putting data here so that we can all collectively have a benchmark for where we are as a healthcare ecosystem to better understand how do we move that forward and what it really is the actionable impact to patients if we make a meaningful change in the data that you see on the screen. So that's the position of I guess, emotional intelligence that we're trying to take today. Specifically, a slide on women in healthcare leadership as well. The good news, healthcare continues to outperform other industries in female representation at all levels of the talent pipeline that you can see very clearly. The source of this is McKinsey has an awesome, you will get the slides, so all of these are clickable links, so you have all of this data at your fingertips. McKinsey released an awesome report just 2 months ago that had all of this detail, and we just decided to include a couple of screenshots along the way. When you look at that significant challenge for leadership in healthcare for women of color specifically, the challenges that women as a whole are faced with are magnified for women of color in healthcare. And you can see those percentages as well, whereas we see generally more equality in healthcare from the workforce perspective in entry level and manager roles. As we start to get to senior vice president and C-suite roles, that starts to diminish, certainly for women of color. Continuing to go, COVID as a case study. We are going to do something a little differently today than we otherwise would. I'll start with macroeconomic data as just a benchmark that shows what can happen if we're not putting needs of communities first. And so I'm starting with CMS's latest release in June, which shows preliminary Medicare results around COVID-19. Right, we are all managing this, and I also want to stop and say to all the healthcare professionals on the phone today joining us, we're so grateful for the work that you do for us to keep us all safe, and it does not go unrecognized and does not go unnoticed, especially by folks like us who are your partners. We're grateful for all of you, but a couple of things that are really insightful to walk through and to think about is Black Americans with COVID-19 were hospitalized at a rate nearly 4 times higher than white Americans. and you can see the per capita numbers there. Black Americans have experienced the highest death rates when compared to white Americans on a per capita basis. And the rate of COVID-19 cases for dual eligible individuals is higher across all age, sex, race, and ethnicity groups as well. And what the dual eligible piece I really want us to remember, because we will circle back on that in the next few slides. So I mentioned we're going to do something a little bit differently today. What you're about to experience is we've asked Dorinda, who works with us from a patient advocacy perspective, to actually tell a story of one of the patients that she's been able to work with and alongside. And at the same time, what you'll see on the screen is the corresponding macroeconomic data, either from CMS, or from the Johns Hopkins Institute, the Center for Health Equity, that corresponds with the pieces of the story that she's about to share. So I'll kick it to Dorinda, and we'll get rolling.
All right, guys. So I just want to give you a quick story about a girl named Brandy. She's 32 years old, single, works as a waitress, and pretty new to Nashville. She's coming here to do music and pursue a music career, as a lot of people do when they move, if you know anything about Nashville being a music city. So for the past few months, she's been back at the restaurant since things have opened back up, but had to pick up another job because of not having her hours that she normally would have. Now, as she began to work both of these jobs, with neither one of them giving her, of course, the health insurance that a lot of us need in order to be able to get checked out like we need to, one of her boss at Publix started to notice that she was a little different than normal. She was kind of slower, more fatigued, not really having the energy that she normally has. So he told her, like, hey, you may want to get checked out. And of course she's like, oh, well, I appreciate your concern, and just kind of blew it off. So she started to attribute it to maybe, okay, she had asthma, and she was like, well, maybe it's just asthma flaring up because her breathing was getting funny. She's like, maybe my asthma is just flaring up. I'll just make sure I keep my inhaler with me, have my medication, and that should knock it out. Maybe rest a little bit. She had started jogging kind of in the mornings, so she was like, okay, maybe I'll just take a little break from that. Now, as time goes on, it's not getting better, it's getting worse. All the while she's still going to work, of course, because she can't lose money. And while she's at work, her boss is like, hey, you really may want to look at that. So she's like, okay, let me finally go and try to figure something out, get stuff checked out. But as she started thinking about it, she was like, oh, like, I hate to go to the doctor. I'm new here. I don't really know who to go to, how to find somebody. And the last experience that she had wasn't really the greatest one. The last one she had went to go get birth control, and she went for a pap smear, but her birth control was kind of messing her up. So she's thinking, okay, maybe I need to switch birth control, like maybe I need to switch my medication, tells the doctor. The doctor's kind of like, I think you're fine. And she just kind of brushes past, and she's like, no, I really think like something's going on with me. The doctor brushes past it, and that kind of left a sour taste in her mouth. The next time she came back, she decided to request, after doing some research on her own, her own medication that she had found online. The doctor was hesitant, but went ahead and prescribed it to her. But just her interaction with the doctor was not ideal. And that being from back home where she was like, oh, I don't really know how to find someone out here. So she winds up getting a good bit worse. And being that she can't, as you can see, she can't work from home, she's not insured, those things wind up causing her to not really think, like, I have to keep working. I can't really spend money when I need to make money. So I'm not going to try to do more to get into the doctor's office. She goes back to work at Publix, falls out in the aisle as she's working. And they take her to the emergency room. When they take her to the emergency room, come to find out she has pneumonia. didn't even didn't even know that it could have been something that serious, because she's thinking, okay, my breathing's just getting heavier, chest getting tight. This feels more like what may have been asthma attack symptoms. Gets pneumonia. Now, knowing that earlier on, had she felt more comfortable, she probably could have went a lot earlier, went to the doctor, gotten antibiotics, and been able to keep the infection at bay. But because she was not comfortable, it leaves her more vulnerable to COVID-19 by catching pneumonia. So while this story, fortunately, is not true, unfortunately, this is a reality for a lot of people of color, particularly Black people and Latino Americans, as you can see the infection rates on the screen. Oftentimes, because there is such a level of distrust amongst people of color and the healthcare system, we refuse to go to the doctor to get checked out for things that could be treated much earlier on to leave us less susceptible to different infections, further disease, especially right now, COVID-19. So the main thing that we need to try to consider is rebuilding that trust so that people of color can start to go in before it's too late and they're not able to pull through whatever it is that they're battling. The hospitalization rates are higher. COVID, as we said, is higher. These things can help be offset if they're able to have good experiences from a smaller level, their interactions being more positive overall within the doctor's offices, the hospitals, their encounters with nurses, everything that they come across. When that creates a positive relationship between them and their healthcare, it helps them in the long run to have smarter and safer healthcare.
Yeah, thanks, Dorinda. And I know that's a bit different from some of the education that we typically provide, but we wanted to really give the voiceover of the patient perspective while also showing how that plays out in the macroeconomic trends that we see. And specifically, if you noticed on the last slide, the hospitalization rates overrepresented in the uninsured number are Black and Latino Americans, who tend to be more sicker when they finally pursue care, which is resulting in higher hospitalization rates and ultimately a higher death rate as well. Moving forward, I wanted to really spend some time here as well, and I'm really excited to show you this. If you've been around our brand or our company long enough, you know that we talk about this often, which is how do we connect racial inequality to patient safety? Provider trust. I mentioned this at the beginning, right? I want to take a second and actually talk about our name. We call ourselves Provider Trust because we believe that a safe healthcare system is one in which all patients, regardless of who you are, what you look like, what your income level is, or level of insurance, you have the ability to trust your provider, right? So that is why we named ourselves Provider Trust. And it's also coming through in the marketing efforts that we try to do to try to raise awareness for some of the tactical work that we do as an organization. Specifically, many of you guys on the phone are clients. Many of you are not, and this may be your first interaction with us. One thing that we do, I hope you recognize that this is not a sales call, but one of the things that we do is we monitor exclusions, right? We check exclusions at a primary source. And you can actually connect this conversation right back to that tactical work that many of you on the phone, whether you're in HR or compliance, actually pursue to try to better your organizations from certainly an efficiency standpoint, but also a patient safety standpoint as well. So I'm excited to take you through some of that data. I'm going to mention a recent study from Johns Hopkins, published in May of last year, that's had widespread industry reaction as it relates to exclusion data, and specifically connecting exclusion data back to Medicare fraud, waste, and abuse. The study is linked when you get the slides. You can go right to the source and read the information right at the primary source, which is an awesome thing to print out, have on your desk when this comes up in budget conversations next year or in your just normal working environment. Being able to have that at your fingertips, we've found to be extremely helpful. But here's what it shows. In the period of 2012 to 2015, the study analyzed 1,364 excluded providers that treated over 1.2 million Medicare beneficiaries and received more than $630 million in Medicare payments. and it analyzed the patient profiles, it analyzed the provider profiles, and started to understand the trends and how these two groups, excluded providers and Medicare beneficiaries, actually interact with each other, and how does it connect back to a central narrative. In 1 year, right, this is some of the macroeconomic data that's really important to call out. How many patients does an excluded provider treat? And the answer to that is 333 in an annual, so almost one a day. How many services does an excluded provider deliver per patient? And that's about 24 in terms of how often are they billing for services. How much money does an excluded provider receive from Medicare? On average in 1 year is $168,000. And what's the average payment per patient to an excluded provider? Is $500. And if we take that a step further, right, we can take that and look at who is the patient that receives care from an excluded provider. And connecting back to some of the macroeconomic data that we just described, that patient profile is somebody who is more likely than not to be non-white. They are more likely than not to be disabled. They are more likely than not to be under 65. And they are more likely than not to be dual enrolled in Medicaid. And that last line is really critical here because we talked about dual eligibles with the COVID CMS report data that came out in June that mentions COVID hospitalization and infection rates and even death rates were higher for dual eligibles. The folks that we talked about earlier in this presentation as being most vulnerable given their patient story, as Dorinda shared, or just macroeconomic demographic data, is also that same profile of a person that's most likely to be treated by an excluded provider as well. And so when we think about racial inequality in healthcare, there's a million different ways that we can take that conversation. What we wanted to achieve on this call today is to really do two things. One, to give you a sense of how important it is to have leadership representation at your organization, to give a better voice and maybe a more represented voice in rooms that we are really speaking about the patient, that often the work that all of us on the call today are working so hard to protect that patient. If that is HR processes or if that's compliance processes, they're inherently connected in having leadership and representation, and also having a specific process, policy, product, or even a procedure that helps keep that same patient safe. It matters, and it's a cultural thing that all of us play a role in. If we take that even one step further, we can understand the patterns of ethnicity as it relates to that patient. Medicare patients specifically treated by excluded providers are more likely to be Black, Hispanic, Asian, or another minority group, and least of all, be white. And then lastly, analyzing the medical diagnosis, right? So Dorinda touched on these as from a patient perspective, but when you look at patients more likely to defer care when they ultimately need it, often when there is a pre-existing condition or a medical diagnosis, we see that care is also more likely than not to be delivered by a fraudulent or an excluded provider as well. So it's an interesting parallel between the two. Medicare patients treated by excluded providers are more likely to be diagnosed with depression, chronic kidney disease, diabetes, or heart disease from a diagnosis code. And it's interesting to connect those two back to the conversations of inequality and inequity in healthcare. Continuing to go, we're going to leave you with actionable next steps for HR and compliance. So many of you on the call today work in HR and work in compliance, and we wanted to leave you with a few specific takeaways. Also, before we get there, I'm going to say one more time because I think it's really important to say is there's a lot of right things to do. Just because we're offering a list here doesn't mean that it's fully comprehensive. We would so encourage everyone on the call to continue to be active listeners, to continue to contribute to the conversation. And what we say at Provider Trust is to continue to stumble bravely in this dialogue and in this conversation, knowing that we'll all be far from perfect, but knowing that progress over time is done one step at a time. And that's how we see real change in this country. So I'm going to kick it to Dorinda to read the next slide.
All right. So the goal, you guys, the main thing we want to see is change within the culture of your organization, and not just bringing in different programs and initiatives. Although those things are great, a lot of times, as soon as money runs out or there's no longer the high emphasis on that specific topic, those programs kind of get phased out. So real organizational change, culture change, is hard. It takes incredible time and effort, but it is possible. It can be done. We can change the way our organizations operate. No one has approached the diversity more holistically, aiming to change its culture, rather than relying on a specifically created diversity program to succeed. Because, as I said, we all know what happens to these programs. You have a program, you have the money to fund it today, but then if there's no money tomorrow, you stop the program. And we don't want to see these things just fade away. We want to see companies change, organizations change, so that people can have better experiences and be able to have more representation when they come into contact with their primary care physician or front desk or everywhere. It helps knowing that you have people that look like you and have a hand in what's going on and bringing those opinions, those thoughts, and those voices to the table as well.
Well said. And we are including in the slides, you get just a case study of Novant. We included a quote from them specifically for the sake of time. We're going to breeze by it, but it will be in the materials that you'll get after this. Connecting HR and compliance, right? So many of you are in HR, many of you are in compliance, and then many of you are in leadership as well at healthcare organizations. And here's just how you can contribute from an organizational or department perspective to this conversation and to equality in healthcare today. We've got 3 more slides and then we'll wrap up. The first one is going from conversation to commitment. And this is something that we work at. I'm referencing the same screenshot that we started today with, which is the next level is going from saying Black Lives Matter to showing that commitment. If Black Lives Matter, then how does that impact your hiring practices and some of how we actually can see change at an executive or senior leadership level in healthcare as well, which is a good challenge for all of us. Actionable next steps, right? So here's the checklist, and the takeaway is we recognize that every organization approaches diversity and inclusion uniquely and differently. Here's a quick list of actionable next steps that you and your team can plan for today. And I'll just breeze through these really fast, which is define diversity and inclusion at your healthcare organization. If you've seen one approach, you've seen one. Everyone looks at this a little bit differently and takes this on differently. Get leadership or executive buy-in and commitment for the long term. Create diversity and inclusion benchmarks and noting your industry as well. And some of that data you'll have access to in the slides and materials that you get. Enlist or hire a diversity advocate or partner along the way that can be your voice. Be transparent about your starting point and along the way as well. Expand your recruiting and hiring pool. And many of you guys have done such good work that we've been able to see. Commit to a diverse and inclusive workforce and ensure your technology is furthering diversity and not the alternative. I'll spend just a second there, as it's so imperative that as we all look at building our tech stacks, building our algorithms, building our data monitoring practices, that what the outcome of that needs to be furthering inclusivity and not being inherently exclusive. Oftentimes we've seen there's an article in the news about a claims processing company in the last 12 months that had an algorithm that was inherently driving a wedge between healthier white patients and sicker Black patients. And making sure that you have your tech stack supporting your initiatives. I can't understate the critical nature of that because we are so technology dependent in the world that making sure your tech is working for you and not against you in the background is so critical to make sure. That includes even just as picking your healthcare monitoring, as we showed, right? Are you having a monitoring tool that actually helps further your patient safety objectives? And then building the foundation. Go ahead, Dorinda.
Oh, go ahead.
The only thing I would leave us with is moments like this are cyclical and they're dependent on the foundation that's laid in between. And so the work doesn't stop, even though there's often a highlight moment in our culture. What happens in the groundwork that we lay, how does that further equality in healthcare is something that we are so passionate about, and we're thrilled to be partners with all of you along that way. So we're going to leave you with 3 resources and then wrap. So a couple of things to take away from today. Again, you will get all of this data, all of the reports, and all of the slides, but there's 2 things in particular. One, we publish a large amount of content, and it's all free at providertrust.com. So if this is your first interaction with us, browse our library on Provider Trust, and actually you'll be able to engage. We have everything from blog posts to guides to checklists to webinars, including the recording of this session and previous others that talk about this topic if you're looking for continued education. And then Dorinda is going to talk about the Health Push, which is a new initiative from our organization as well.
Yes, you guys, on October 27th, we are super excited about this event. It's all virtual. It is just one day. It's free. You can go to thehealthpush.com to sign up. We have lots of amazing speakers. Our objective is simply to just have a day of structured conversations around racial inequality and racial inequities within healthcare. So we're covering things like maternal health and COVID-19 and how the disparities, like what you saw from the charts earlier in the presentation, what those show, discussing things like that, as well as hearing from the patient's perspective as well. So hope you guys can sign up for that. We're also going to have some cool little breaks in between with music and poetry and video. And so it's fun. It's going to be interactive. You'll be able to send questions through if you have those for some of the panels or at the end of the seminar. So definitely be sure to go visit thehealthpush.com. We're also on Instagram and Twitter. But visit both of those, sign up, and join us for a great day of conversations.
Awesome. Last thing, guys, a couple of ways to stay connected with Provider Trust, and then we'll leave you. Just as always, please be safe and please be well. These are interesting times we live in. We are so grateful that you chose to spend 30 minutes with us today. Thank you for the time. You'll get all the materials and all of the good stuff after the session today, but we're grateful you chose to engage with us in this topic and in this conversation. Thank you, friends. Be safe, be well, and that is it.
Yes.